This is the accompanying presentation for the chapter on medical and surgical management of chronic subdural hematoma for the 8th edition of Human and Wins Neurological Surgery. We give a brief overview of the chapter, including pathogenesis and clinical presentation, but focus mainly on some pertinent points regarding choice of treatment and the technical nuances to optimize surgical management. Studies have shown that the incidence of chronic subdural hematoma is rising, and this has been attributed to the aging population and the increasing use of anticoagulant and antiplatelet medication. Specifically, the incidence is rising in those above 70, and given that the world's population is continuing to age, the incidence of chronic subdural hematoma is set to rise even further. Chronic subdural hematoma arises at the dural border cell layer, a layer of cells between the dura mater and the arachnoid mater that has less intracellular collagen and is therefore prone to separation. There are two pathogenic mechanisms, the first from an insult causing an acute subdural hematoma, and the second from a subdural hygroma that then undergoes hemorrhagic transformation. Irrespective of the initial origins, progression of the chronic subdural hematoma is thought to be due to inflammation, angiogenesis, and fibrinolysis, which slowly result in hematoma expansion and mass effect causing symptoms. Clinical presentation can be vague and nonspecific, especially in the elderly who may have pre-existing cognitive impairment at baseline. Patients can also present with multiple complaints, as illustrated in the table, which is from a UK multi-center study of over 1,200 patients with chronic subdural hematoma. The delay from initial symptom onset to presentation can be between days and weeks, and following presentation the diagnosis is usually made on an unenhanced CT scan. Classifications for the CT appearances of chronic subdural hematoma exist, although apart from noting the presence of membranes, this is not really used to guide treatment. It is accepted that patients with symptoms that are attributable to a chronic subdural hematoma should undergo surgical management. However, there are a number of steps to consider in the treatment paradigm, including preoperative optimization, choice of surgical approach, tools to reduce the recurrence and complications, and postoperative care and rehabilitation. In terms of preoperative optimization, there are three main steps to consider. At our institution, procedures are carried out under general anesthesia where possible, so patients need to be worked up and optimized for this anesthetic. This can be performed either at the referring unit or at the neurosurgical center. The input of anaesthetists and elderly care physicians is important in this process. Many chronic subdural hematoma patients are also on anticoagulant and antiplatelet medication, and these need to be reversed in the perioperative period, both to ensure the safety of the surgical procedure and to reduce the chance of postoperative recurrence. This can be carried out according to local protocols, and the surgery should be scheduled for when this has been normalized if possible. For example, if clinically permissible, surgery can be delayed for 7 days following the discontinuation of aspirin. Adjuvant medication may also be considered at this stage. Although there is no level 1 evidence for any medical therapy at the moment, there are a number of randomized controlled trials currently being conducted for steroids, which should provide answers in the near future. The three main surgical options to treat chronic subdural hematoma include, from smallest to largest, twist dural craniostomy, burr hole craniostomy, and a craniotomy or mini craniotomy. The choice of which procedure to undertake is largely dependent on the surgeon and institutional preference, although less invasive techniques may be favored to reduce the physiological stress on the elderly patient. At our institution, the majority are treated with burr hole craniostomy under general anesthesia, unless there are specific factors such as membranes, high-density components, or recurrent collections following initial burr hole drainage, which may necessitate consideration of a mini craniotomy. We thought we would use this opportunity to highlight a number of technical nuances in the surgical procedure to try and reduce the risk of recurrence and complications. The first involves the number and location of the burr holes. We believe that 2 burr holes should be used as it provides better exposure, especially during the irrigation phase of the procedure. The location should be tailored to the location of the hematoma, but in the vast majority, placing the frontal burr hole at the Stephanion and the parietal burr hole at the urion provides optimal access. As will be illustrated in the next slide, There is ample evidence that using drains reduces recurrence and optimizes functional outcomes following surgical drainage of chronic subdural hematoma. We advocate placing a subdural drain anteriorly via the frontal burr hole wherever this is technically possible. In order to reduce the rate of potential injury to the underlying cortex and cortical vessels, we suggest fashioning a tangential burr hole to allow the drain to slide into the subdural space. This can be achieved using a high-speed drill. Some of the best evidence for chronic subdural hematoma management surrounds the use of drains. A single-center randomized controlled trial at our institution in 2009 showed that subdural drains reduced the recurrence from 24 to 9.3% and reduced 6-month mortality from 18 to 8.6%. These figures were reflected in a real-world practice study almost 10 years later in the UK multi-center chronic subdural hematoma study, which showed that failure to insert a drain was an independent predictor of recurrence and unfavorable outcome. Drains have also been shown to improve long-term outcome even at 5 years following the procedure, and a recent study has highlighted the importance of translating this evidence from randomized controlled trials to everyday practice. Good postoperative care is as important as meticulous surgical technique. There is no evidence that bed rest, which may be detrimental to the physiological reserve in elderly patients, reduces recurrence. We therefore encourage early mobilization and rehabilitation. All postoperative patients should be considered for mechanical and pharmacological thromboprophylaxis, and we usually commence pharmacological thromboprophylaxis once the drain has been removed. The choice of whether or not to restart anticoagulation should be an individualized decision, and multidisciplinary input from cardiology, hematology, and geriatrics can be helpful in guiding this process. The timing and dose at which to restart should also be tailored to the individual, although there is evidence that early resumption, as soon as 3 days after the operation, may be safe. In terms of follow-up, there is now randomized trial evidence to suggest that routine postoperative imaging does not alter management and is therefore not indicated. We usually review patients in the outpatient setting 2 to 3 months following the procedure, at which point the vast majority are discharged from further neurosurgical follow-up.